good. So next I want to invite Dr. Secemsky. He's the Director of Vascular Intervention at Bethesda Deaconess Medical Center with the Harvard. His topic is it time to use imaging to tailor our therapy for BTK disease? So really, really appropriate for what we're dealing with.
Thank you. Yeah, this is working out really nicely because we just saw that great IVUS run. So I've been building out this deck over about 5 years now, so I'm going to try to give you the most updated data, primarily for IVUS, for any inframe window, and then some focus on BTK as well, and then we'll get back to Miguel. So, I think we've had to learn a lot over the years the hard way. There's been a number of failures in the infrapopliteal space in the US in particular, Impact Deep, Lutonix BTK, most recently the Saval trial with Boston Scientific. And one thing that we all recognize is sizing of tibial vessels is particularly challenging due to their small caliber and distal nature. And as a rule of thumb, as everybody knows, if you can't get the drug to the wall, it's not going to work. So appropriate sizing is absolutely critical, both for scaffolding as well as for drug delivery. I think most trials now, you'll see that with trial design, there's at least a recommended with a push to even do mandatory IVUS utilization, really both to improve the performance of these devices and learn more about when they do fail. And again, I always put this kind of comment at the bottom, and Miguel gave us such a great example of using IVUS as guidance and not just using IVUS to say you use IVUS. So we really do a really prescribed approach to using intravascular imaging to guide our therapies. And everybody knows this pattern of trade-offs. And so if you have insufficient angioplasty, you're left with recoil, and I'll show you some data on that and restenosis. If you have excessive angioplasty, you have barotrauma, which results in early neointimal hyperplasia. So, really the goal is what we call controlled angioplasty, which is appropriately sized, appropriately timed, and Fadi gave us a really good example of this earlier, but to achieve our goal of improving outcomes without increasing our risk of restenosis. And failure to eliminate those tensions of recoil really result in early changes to the vessel that are not apparent with initial angioplasty. And so we've learned a lot also about this over the last few years about the early recoil patterns that can occur if you take the patients and do another angiogram 5, 10, 15 minutes after your initial PTA. So again, sizing and addressing this is important. We have more devices coming in the market that will be accounting for this. But again, you have to recognize this failure mechanism. On the opposite side, again, is the barotrauma. And so here is a nice picture of a TP trunk. You can see it looks great in an angiogram. Most of us may have walked away at this point. And on the IVUS, you can see a deep dissection extending into the adventitia, is highlighted by this chroma flow outside the vessel. And residual dissection is one of the #1 predictors of infrapopliteal restenosis. It's under-recognized, and up to half of cases have them, yet we don't recognize them with the angiograms alone, in particular if you're not doing orthogonal views. Here's another histologic demonstration of what looked like an angiographically normal patent vessel on the left on this angiogram, and then you can see a significant area of both residual stenosis and microdissections. And again, you wouldn't know this just looking at the angiogram itself. So what does IVUS provide? There's a number of benefits that IVUS has over angiography. Again, these are complementary. We're not doing IVUS-only procedures, but the goal is to augment our angiography limitations with a three-dimensional view of the vessel lumen. And so we get a much better understanding of stenosis, plaque burden, as Miguel just showed us. We saw also with Miguel understanding that guide wire orientation. Are you in that sub-intraluminal space? When you're looking at this, as soon as I saw it, you look at so many of these, I already knew exactly where he'd exited and entered. He did a wonderful job demonstrating how to mark this on his angiogram to avoid it or be different in that territory. And then also looking at dissection and thrombus is critical. Flow is something that we're working on, and very heavy IVUS users have a lot of comments on the ability to look at flow, in particular with chroma flow, but that has not been as adjudicated yet. So another comment on sizing, this comes into my slide deck all the time, is what do we miss even with digital subtraction angiography in a controlled manner versus IVUS? And you can see why our concerns about device failures in the past are due to undersizing. A proximal anterior tibial, as taught to the average person, is 2.5 millimeters. In reality, an IVUS is up to 3.5 millimeters. When you look at a tibial perineal trunk, this can be up to 4 millimeters, and even our perineal vessels can be more than 3 millimeters on average. So we have this pattern of wanting to downsize our peripheral infrapopliteal devices when we really need to be sized absolutely accurately as we move into the drug era. And again, there's a number of different programs that have looked at adequate sizing improving outcomes. In this one study, they looked at 12 below-the-knee cases where they compared both QVA, or quantitative angiography, to intravascular imaging, and nicely demonstrated that with intravascular imaging, they would get more luminal expansion and overall better end reference vessel diameters. This study from Fujihara et al. Came out looking at infrapopliteal use of IVUS for outcomes, 216 patients with CLTI, and they demonstrated again that with IVUS we use larger devices, we can improve both wound healing, skin perfusion, and overall outcomes, and this was a great paper really demonstrating that. We've moved more and more towards also using IVUS for our suprapopliteal vessels, so SFA pop disease as well. And again, as we have DCBs on the market in the US for this femoral popliteal segment, we're getting better with understanding also our luminal versus EEM measurements. So again, a luminal measurement can also undersize, in particular a diseased vessel, the full caliber of the vessel. And so in this study, they looked at EEM, so the external elastic membrane, which is a healthy stripe in the media of the vessel, versus luminal measurements, and again, demonstrating, don't look at these small Kaplan-Meier curves, but better outcomes if you use a larger balloon, size to the EEM, in particular with drug-coated technology. Now, data here is evolving, and this has really helped us, again, with a lot of the concerns we've had with reimbursement issues and payers not wanting to cover our devices. These are the studies and programs that help protect our reimbursement. And so we have 2 randomized trials now. Again, this is now in the femoral popliteal space, not BTK. The first was from a group in Australia looking at IVUS with angiography versus angiography alone from the femoral popliteal segment. At 1 year, there was a 17% improvement in restenosis, and this is really driven by better sizing and appropriate use of drug-coated balloons. So there was almost no restenosis in those who had an IVUS-guided DCB placement. These data have been now followed up through 2 years. This is from Verb last year, and again, showing that continued separation in curves and binary restenosis out through 2 years. In March of this year, we had a second randomized trial that came out of Asia. This was at 237 patients, again with IVUS and angiography versus angiography alone. And again, in blue here, IVUS outperformed angiography in terms of primary patency, as well as target lesion revascularization through 1 year. And if you look at IVUS in particular, and again, going back to Miguel's cases, it's not the task AB lesions. I think we all have a pretty good algorithm, good sizing. Those tend to overall have better patency. It's a more complex disease that really tends to benefit from intravascular imaging. When we extend the trial data with patency and restenosis endpoints out to clinical outcomes, we go back to our real-world evidence. This is a large study we did several years ago, 500,000 patients, and we looked at IVUS in red versus no IVUS, demonstrating improvements in major adverse limb events, acute limb ischemia, and major amputation. And when you only look at the infrapopliteal segment, again, that's where a majority of our IVUS guidance was. A lot of operators in the US are using IVUS for infrapopliteal in particular. Again, you see a highlight in improvement in major adverse limb events, some small reductions in acute limb ischemia, and even some signals of improvement in major amputation. I'll just show you a few more slides and get back to Miguel's case. This is a meta-analysis of everything I showed you and more. 600,000 patients. This was published in JVS last year. Again, the 26% improvement in primary patency if you use IVUS for infrainguinal interventions, and again, a 26% reduction in major amputation. This is the largest meta-analysis published to date. And we went to do a consensus document on this, looking specifically at the use of IVUS throughout the procedure. And I'll just highlight that the most strongest recommendations here in green, this was in JACC interventions a few years ago, was for the tibial vessel. So out of all the voting panel, everybody felt the most strongly about the appropriate use of IVUS for BTK intervention. Cost effectiveness, any costs related to IVUS tend to disappear in the weeks to months after use. So we have the device cost up front. We do have reimbursement in the US covering this. This is on the left, actually Japanese data. On the right is German data. And as you extend the follow-up period, you reduce a intervention, you reduce an amputation, you reduce a hospitalization, you make up the cost of the IVUS catheter quite quickly. I just want to highlight that we have a very strong multi-societal guidance document out. All the major societies participated, again, supporting the use of IVUS. And if you have interest in learning more, there's a QR code here. It has some good teachings there. So we'll go back to the case, hopefully, but I just want to highlight that we've really made a lot of progress in the data supporting the role of IVUS. You can see how it's influencing this case in particular, and we're really proud to have this on ourselves with reimbursement in the US. Thank you very much.